Good morning. Good morning. Thank you. Okay, just making sure you've had enough coffee. I'd like to welcome you. I'm Jane Clark. I'm the Dean of the School of Public Health here at College Park. We're probably going to have a lot of people come in. I understand Route 1 is doing its usual play up just before we have this. We're pleased this morning to welcome you to the second annual Public Health Research at Maryland Day, and what a day we have in front of us. I said I was pretty happy when we had two Surgeons General who would be joining us on the program, but I understand our current interim Surgeon General will also be joining us at some point today as well. So taking advantage of our unfair advantage of being just up the street from Washington, D.C., we will do that. So we are pleased today to partner with the University of Maryland at Baltimore, and specifically the Department of Epidemiology and Public Health, which we will be collaborating with as we form a collaborative school of public health that if we didn't have Route 95, we probably would do much more successfully. Unfortunately, their chair, Dr. Jay Magaziner, could not join us today, and it looks like Dean Reese has not made it yet down the road, but I'm sure he will appear at some point. But we'll have another representative from the University of Maryland to offer greetings. That would be Dr. Jarrell, who probably doesn't know he's supposed to say something later. I see you in the back, Bruce, going, really? Yeah. Mm-hmm. We are especially gratified to have the U.S. Public Health Service as a new partner through the U.S. Commissioned Officers Foundation, and Dr. Farrell will be talking to us at some point after some greetings. This is a real unique opportunity, and since I see a number of commissioned core people here. I go in the morning to work, and I have an admiral on one side of me and a colonel on the other. And as a person who's a civilian, it's like I just have to come in and salute. It's a daunting thing for me. But I'm very pleased that I have. Not on loan, actually. They work for us all the time, and they do a great job. And they actually, I think it must be the military, you give them a task, and it gets done. It's wonderful, yeah, as opposed to us academics, where it might get done. So today, our conference theme is Leadership for the 21st Century Public Health. And I think we couldn't be luckier than to have the two Surgeons General here today. They'll speak in a moment, but I'd like them to stand for a moment, Dr. Satcher and Dr. Carmona. And if you could just welcome them with a hand. How very impressive their work has been, and one of the reasons this is so exciting is in 1964, when I won't tell you where I was in school, but it was a memorable year for me. They released the Surgeons General report on tobacco and health. It's just amazing to me that was 50 years ago. I was graduating from high school. And 50 years ago, we told you it was bad to smoke, and today still 18 to 20% of Americans still smoke. Really? Is that really the case? I can't believe it, but you're on a smoke-free campus, though, I have to say. So you have to go out to Route 1 and stand on the highway if you want to have a cigarette. So, our other special guests that are joining us today later on will be our provost, who's a chief academic officer, and Dr. Bruce Jarrell. Would you raise your hand back there? He's the chief of chiefs. He's the chief academic officer for the campus at Baltimore, University of Maryland-Baltimore, and he will talk to us in a few minutes. This is our second annual, as I said, Public Health Research Day at Maryland, and it builds on all the interests that we had last year. Last year we had, I think, a number of breakout tables, and this year we're sort of building on those, and as you'll see in your program, hopefully you've either registered or have the program, you'll see that there will be breakout sessions later, and then that we have over 106 posters that will be presented. This year we're especially fortunate to have, as I said, our two Surgeons General, and I will be getting out of the way in a few minutes to let Dr. Satcher speak. But as those of you who know me, I love numbers. Actually, my scriptwriters wrote a note saying, Jane, you have to say that you love numbers, but there are 600 people. They're not all here this morning yet. 600 people registered for this conference. There are, of those 600, 85 are undergraduate students, 159 are graduate students, 145 are faculty. We also have staff, 42, but the largest group are public health professionals. And that's actually one of the reasons we do this. It's not just for us. We have classes and we have seminars and we have our grand rounds, but having this day where it's free, you can come down here and engage in all this wonderful public health research and knowledge sharing. We also have participants from 7 different state and local health departments, and again, 38, so who's keeping track of your United States Public Health Service Commission Corps has 38 people here, but who's taking attendance? No. And there are 13 different universities, and apparently we let Drexel in here. This is, public health in Maryland. What is Drexel doing here? I mean, no. Okay, where is Drexel? No, not here this morning, too early to come down this way. But we also have Howard University, also from, not in the state, Coppin and Morgan State, as well as the University of Maryland, College Park in Baltimore. The student posters will also be judged, and if you stay around for the whole day at 3:30, there will be a recognition of them. There'll be categories for undergraduate student, master's student, and doctoral student awards for best posters. So go around and be sure to ask some questions of the students and get back to me if they don't give you a good answer, okay? No, I hope, give me your feedback if they're great answers. So at this point, I was supposed to introduce Dean Reese, but I wonder if Dr. Jarrell would like to just send greetings from the University of Maryland, Baltimore. I know he said, Jane, I don't have anything to say here, but I would appreciate that if you would. And then if you would, come back to me then. Okay, great. Thank you.
Thank you. And greetings. I'd like to say from the University of Maryland-Baltimore, but I don't think that way at all. I think of greetings from the University of Maryland, both universities. And certainly it's taken a long time for us to get our two universities to this point. But I couldn't be more pleased with the progress that we've made in growing this program. This is the second year of this conference. It's wonderful that we have so many other universities represented, but it's also wonderful that we have our two universities represented. As I've spent time at the two universities, I've learned just how influential the faculty at each university is in terms of the state. I've learned how important the medical school is in the health of the state. I've learned how the public health programs are important in the public health of the state. I've learned how the law school faculty influences public policy in a major way. And I've left out a whole bunch of other schools, all influential in their own way. So I'm looking forward very much to this conference because I suspect that this conference will be influential in the way the state views its health and the health of its citizens, et cetera, on a very important topic. So welcome to this conference, and I'm going to have my ears open to hear what new things come out of this group, and especially welcome to our two Surgeons General. Thank you for being here. How do you say surgeons, plural, surgeons in general? Surgeons in general? Thank you.
One of the things that having Dr. Jarrell speak reminds me that the major funder of this is the Empower the State program, which is the way the state legislature is trying to encourage the two universities to work together. And so Empower is the source of our funding, along with Captain Farrell. If you would join us, this Captain Farrell is the head of the Commission Corps Foundation, is that correct? If you would come up and give your greetings.
Well, good morning. I'm delighted to be here. Dean Clark, Dr. Jarrell, Surgeon General Satcher, and Carmona. Ladies and gentlemen, On behalf of the trustees of the Public Health Service Commissioned Officers Foundation for the Advancement of Public Health, I'm delighted to welcome you all to this Public Health Research Day at the University of Maryland. Our foundation and affiliated association of Commissioned Corps officers is delighted to partner with the University of Maryland School of Public Health in presenting Public Health Research Day at Maryland 2014. The day's theme, Leadership for 21st Century Public Health, is a topic of paramount importance to our foundation and association. And we're pleased to be able to participate today and facilitate two of the great public health leaders of the 21st century, Surgeon General Satcher and Surgeon General Carmona. Both, I would mention, are honorary trustees of our foundation, and we're delighted for that. Acting Surgeon General Boris Lushniak, as has been mentioned by Dean Clark, will be here later this morning, and I can assure you that Admiral Lushniak continues the strong leadership for our nation's public health that marks the role and marked the careers of Surgeons General Satcher and Carmona. The importance of strong, committed, and courageous leadership in public health cannot be overstated, and neither can the role of the Surgeon General and the officers of the Public Health Service Commissioned Corps, led by the Surgeon General, in promoting that leadership. Two recent examples, one's already been mentioned by Dean Clark. This year we celebrate the 50th anniversary of Surgeon General Luther Terry's report on smoking and health, a report compiled under the direction of the Surgeon General and other PHS Commissioned Corps officers, and a report that has changed the way the world views tobacco use and saved millions of lives in the process, and still has an impact on each and every one of us today. A fact mentioned by Dean Clark, this campus is a non-smoking campus. The Public Health Service Commissioned Corps, one of the 7 uniformed services, and the first of those 7 services to go non-smoking, no tobacco use in uniform and on duty on January 1st of this year. And we encourage the other uniformed services to get on board and follow suit, and we're pleased to see that Secretary of Defense Hagel is moving in that direction now. And as a former naval officer, I'm happy that the Navy is leading that charge in the Department of Defense. In 1988, Surgeon General Chick Coop wrote to every household in the United States about the growing HIV/AIDS epidemic and put the country on a path to addressing that public health issue on a scientific basis rather than a moral and emotional basis. The preparation of such leaders as Surgeons General Satcher, Carmona, and Coop begins with public health education, and that is why you all gather here today. Our foundation and association are proud to partner with the University of Maryland School of Public Health in supporting advanced education for PHS Commissioned Corps officers, and we are equally pleased to use the opportunity afforded by this event to introduce students here at the university and the other universities represented today to the tremendous opportunity to serve, to serve public health in the Public Health Service Commissioned Corps. Thanks very much for your participation and attendance today. I look forward to meeting you as many as I can as the day wears on, and I hope you have a great and educational, informative day. Thank you.
So thank you, Captain Farrell. Without further delay, I'd like to introduce the School of Public Health Associate Dean for Academic Affairs, Sandra Quinn. Sandra is not only the Associate Dean for Academic Affairs, but she is also the Senior Associate Director of the Maryland Center for Health Equity, which is an NIH Center of Excellence committed to eliminating health disparities, a movement that gained national attention and traction under the leadership of Dr. Satcher during his service when he was the 16th Surgeon General. So it's even more fitting that Sandra would be the one who would introduce you this morning. Thank you, Sandra.
Thank you, Dean Clark. Good morning, everyone. It is my great honor to introduce Dr. Satcher to you this morning. Dr. Satcher was the 16th U.S. Surgeon General, and he simultaneously served as the Assistant Secretary for Health from 1998 to 2001. While he served as Surgeon General, he issued reports on mental health, oral health, suicide prevention, tobacco and health, sexual health and responsible sexual behavior, youth violence prevention, and obesity. He was, as Dean Clark mentioned, the first Surgeon General to call for the elimination of health disparities and he continues to lead in that effort today. Prior to his service as Surgeon General, Dr. Satcher was the director of the Centers for Disease Control and Prevention and the Agency for Toxic Substances and Disease Registry from 1993 to 1998. Among his other achievements at CDC, Dr. Satcher spearheaded the movement to secure an apology to the survivors and the family members of those who were affected by the U.S. Public Health Service study of Tuskegee at Tuskegee. So he led that effort, which resulted in President William Clinton apologizing to those survivors and their families in the White House. A graduate of Morehouse College, Dr. Satcher earned his MD and PhD from Case Western Reserve University. We have a Case Western alum back there. I happen to know that. His past positions have included serving as professor and chairman of the Department of Community Medicine and Family Practice at the Morehouse School of Medicine and president of Meharry Medical College in Nashville, Tennessee. Dr. Satcher has received 18 honorary degrees. His awards, which are too numerous to mention, do include those from the American Medical Association, the American College of Physicians, and the American Academy of Family Physicians. Currently, Dr. Satcher serves as the honorary chairman of the African American Network Against Alzheimer's. In a February 21st, 2014 column in the Washington Post that I'm hoping many of you read. Say yes, you did. All right, good. He brings his scientific knowledge and his personal passion to the need to address one of the most worrisome diseases in our country right now, and its particular disproportionate impact on African Americans. I'd like to quote Dr. Satcher here. Alzheimer's cases in the United States are projected to triple from 5.2 million to nearly 14 million by 2050. In other words, these problems are going to get worse before they get better. Researchers believe it is possible to stop Alzheimer's with investments and research equal to the size and the scope of the disease. But funding can only go so far without a corresponding increase in patients willing to participate in innovative clinical trials. He calls specifically upon African Americans to lead by example. In doing so, we might just gain meaningful insight into the causes of the disparate impact of Alzheimer's and help speed our pace to a cure. Help me welcome Dr. Satcher.
Thank you. Thank you very much. Thank you. Thank you very much, Sandra, for that very kind introduction. I'm delighted to be here to Dean Clark and my good friend, Surgeon General Carmona Rich, to Captain Farrell, and to all of you distinguished people. I'm delighted to be here. I bring you greetings from the Morehouse School of Medicine in Atlanta, where we have the Satcher Health Leadership Institute, which I'm fortunate to be able to lead. I'm still recovering from last week. I was telling some of you that we had a reunion of sorts of those of us who served on the World Health Organization's Commission on Social Determinants of Health. And it doesn't seem like it, but it's been 5 years since we released that report. And we gathered at a great place, the Rockefeller Conference Center in Bellagio, Italy, to really look at where are we 5 years later and where do we go from here. And it was a very productive meeting. And I think it's going to make a difference as we work with the World Health Organization and UNICEF and UNDP, and others in trying to make sure that the approach to global health equity through the focus on social determinants of health continues to grow and to gain strength, not just in this country, but throughout the world. There were people there from India and Africa and Egypt and Brazil and Japan, and it was a great group of people. But I'm happy to be here. That's an excuse that I'm still jet lagged, but I'm fine. And I'm energized by this conference. I always am energized by the University of Maryland. I was here when the School of Public Health started, and I'm back. But I'm so proud of what you've done at this institution. I think you have been a pace setter in many different ways, and it's just great to be able to join you again. At the Morehouse School of Medicine, we take the goal of eliminating disparities in health very seriously. It's a part of our mission statement. And of course, at the Satcher Health Leadership Institute, the focus is on helping to develop leaders for that role, but also leaders for the vision, I would put it, of global health equity. We believe that it is an appropriate vision for this world, and so we're very pleased to be a part of it. Some of you knew J.W. Lee. J.W. Lee was an outstanding public health leader. I had a chance to work with him when I was director of the CDC, especially on programs like rollback malaria and other infectious diseases. I was a little surprised when J.W. called me in 2004 and said, David, I know you've said you're not going to join any more boards or commissions, but I have a special one for you. He said, we really believe that we can achieve global health equity, but it's going to be a long, hard road. But one of the things we are concerned about is the fact that we're not adequately targeting the social determinants of health. So with that, I agreed to join the Commission on Social Determinants of Health. Now, that was, I think, about November of 2004. J.W. Lee joined us in Chile in February of 2005 for our first meeting. And then in May, of course, he suffered a stroke and went into surgery and didn't survive. So he was not around for the release of the Commission's report. But I hope all of you remember that name, J.W. Lee, because he contributed so much to public health in this country and in the world. And he contributed the vision of targeting social determinants of health. Well, I want to talk briefly about three things today, and I hope that we can have a lot of time for questions and comments at the end. That's my favorite. I tell audiences all over the country that the favorite part of my presentation is the question and answer period. I really enjoy hearing feedback, and even the questions I can't answer, I still enjoy getting them. So I'm looking forward to that. Let me just say that the mission of the Satcher Health Leadership Institute is about helping young people to develop their leadership skills, but we believe that it's also important for us to be involved in leadership and not just a program that works with young people to develop them, but to be active in the community in providing leadership so that our fellows and our students are able to become involved with us. And so we're involved with strategy development, we're involved with developing policies and practices and based on the best available public health science, and working with our students and fellows in the community. And it's all of course, geared toward that goal of reducing and ultimately eliminating disparities in health. Now, I want to make it very clear, because I'm not sure this was clear when we released the goal of eliminating disparities in health. It's not just about race and ethnicity, and I hope you know from my reports that when I talk about disparities in health, mental health is right up there. We have worked very hard to make sure that people with mental disorders do not suffer from the social stigma that hurts so many individuals and families, and that they have access to care. The major recommendation of the Surgeon General's report on mental health was parity of access to mental health services. And I have to tell you, that was December 1999, right? It was not until October 2008 that President Bush signed legislation for parity of access to mental health services. And even then, it was not complete because it allowed insurance companies to really get away with saying, well, we don't offer mental health services, so we don't have to worry about making sure they're equal. So, but I was really pleased that the Affordable Care Act made it very clear that all insurance companies had to offer mental health services, and they had to be on the same basis of other health services. So we've come a long ways, but we also have a long ways to go. At our program, we're involved in 2 or 3 kinds of activities. We are integrating mental health and primary care at 10 community health centers in and around Atlanta. And also, we took over the mental health emergencies services in Grady Hospital, the largest public hospital in the South. Took that over 3 years ago. And we've demonstrated that for people with mental health emergencies, we can provide quality care in the emergency room. We can dramatically reduce waiting time. We dramatically reduce the use of restraints. And what the hospital was most interested in, we dramatically reduce costs by 40%, and able to get people with mental disorders involved in a continuity of care program. So when we say disparities in health, we certainly include mental disorders and sexual preferences, and we believe that it's important that we deal with issues that separate so many people and isolates them often from the health system. So that's one of our areas of interest. And thirdly, the area of disabilities. Every year we have at least one fellow whose focus is on disability and making sure that the health system is responsive to the needs of people with disabilities. So I just hope you keep in mind that when we talk about disparities in health and global health equity, we cannot forget about the mentally ill. That has people with severe mental illness have a life expectancy that's 25 years less than the rest of the population. It tells you a lot, doesn't it, about what's happening in the system. So we have a lot of work to do in that area. Now, whenever you talk about leadership development, you get an interesting response. And some people say, well, you know, I thought that leaders were born, not made. And I said, well, you know, if that's true, then a lot of us are not doing what we were born to do. But seriously, I think, you know, Hank Aaron is a friend of mine. We're celebrating this year the 40th anniversary of his breaking the home run record. So it would have been interesting for people to argue that Hank Aaron doesn't need to go to spring training, and he was a born home run hitter. So it doesn't make sense to think that we cannot help people to be better leaders. My attitude is that if the only thing I contribute is to make sure that the people coming behind me don't make the same mistakes I made, that alone would be worth the whole program. But I think we have to be willing to share. We have to be willing to share our successes and our failures, so that in fact, the people who come after us will have a head start, in essence, when it comes to leadership, and we can do that. We have a philosophy at the Institute about leadership, and one is that we can't afford to try to leave the emergence of leaders to chance alone, that we actually have to work toward it. But also another philosophy, which has been very important to me, is that at our institute, everybody teaches and everybody learns. Everybody. So when we talk about our leadership development programs, we bring in people, including not just the health professionals in our fellowship program, the community health leaders who come and spend 12 weeks with us, or the parents. We have about 100 parents a year who spend time studying how can we better enrich the early lives of children from 0 to 5. And it may well be the most important program we have, because I'm convinced that if children are able to get a healthy start in life, and I mean health in the broad sense of the word, they gain something that nobody can take away from them. I'm sure many of you have heard me say that neither of my parents finished elementary school, and yet what I remember about them is that they were great parents. What they had to offer, they offered. They cared. They were community leaders and sharing with people in the community when other people didn't have food. And you know, you live on a farm. There are times of the year if the crops are not right where you may not have food. But they were a part of a community where people shared. So I learned my most important leadership lessons actually from my parents. When I was getting ready to leave Anniston to go to Morehouse in 1959, I, of course, had worked with my father in the fields and in the foundry, but he took me to the bus station where I was going to catch the Greyhound bus to go to Atlanta, to go to Morehouse. Morehouse had difficulty with me. They had never heard of my school, and they didn't know what Calhoun County Training School was. So they finally said, okay, we will offer you a tuition scholarship, but you have to keep a B average, and we'll promise you that you can get a job as long as you're willing to work. So I decided I'd catch the bus and go to Morehouse. And my dad took me to the bus station, and I was concerned because he had always given me advice. And my attitude was that, you know, there's nothing he can tell me. He's never been on a college campus. Nobody in his family has ever been to college. How can he? So I was feeling sorry for him. And then as I was getting ready to get on the bus, he said, David. I said, yes, Dad. He said, I want you to promise me something. And I said, what's that? He said, you know where you're going, I'm sure you're going to meet some very important people. Most of them are going to have more than you. And you may meet some people who have less than you. I want you to promise me that you will always treat everybody with respect. And I can stand here today to say that in all of my career, I have not received any better advice than that. It influenced what I did as a student at Morehouse. It influenced what I did as a Surgeon General, because I believe that people with mental disorders deserve to be treated with the same respect as other patients, as other people. So that advice. We believe that leaders have to be prepared to respond to opportunities and challenges and even crises. And we seem to have our share of those in this world. We believe very strongly that leadership is a team sport. It took me a while, you know, after I became president of Meharry to realize that, you know, the most important thing I need to do up front is to get a team. I need to really invest in a strong team, some of whom will know more about some things than I do. But I think often we fail to realize that leadership is, in fact, a team sport. And that leadership is not position dependent. You really do have to listen to people on your team. And I listened to a lot of people when I was director of the CDC. And some of them, of course, contributed to the decision. Steve Thomas, of course, served on that commission on Tuskegee. And back, I remember very well, and they presented a very strong report to me. And I felt empowered when I talked to President Clinton and Donna Shalala about the need for an official apology. But it was a team effort. Effective leadership transforms communities. And we're in the business of trying to transform communities so there are places where people can be healthy. And it requires a global perspective. But I want to say a word about leadership as a relay race. As a student at Morehouse, I ran a little track, and some people would underline little. But I ran track, and I ran distance. But my favorite race was the relay race. I loved to watch the relay race because it was such a team effort. And you know, you had to pass the baton. Somebody had to receive it smoothly and hopefully run faster than you did. And I just see that as an example of a team approach. The only thing I regret is that they don't have a long-distance relay race. You see, because when running the 2-mile and the 3-mile, I often wish that I could pass the baton on to somebody else. But you know, seriously, I want to say a word about the 50th anniversary of the first ever Surgeon General's report. And I know Rich Carmona is going to talk a little bit about that later. But, you know, I've been thinking a lot about those 50 years. 50 years ago, when Luther Terry released that report, in many ways, the Office of the Surgeon General had begun to lose power and authority in terms of position, right? If you go back to 1873, most of that history, the Surgeon General was head of the Public Health Service, clearly. But starting, I guess, with the development of the Department of Health and Human Services, that started to change. And so when Luther Terry released his report in '64, the Surgeon General didn't have the same positional authority. But I argue that the Surgeon General's office gained credibility while losing authority. I'll say that again. I think the Surgeon General's office gained credibility while losing authority because the American people, starting with that report, started to look to the Office of the Surgeon General for reliable information and advice based on the best available public health science. Not politics, not religion, not personal opinion, but the best available public health science. And I tell people I have all three, but the reports from the Office of the Surgeon General were based on the best available public health science. The fact that the Surgeon General will not release a report unless it's signed off on by the best scientists at NIH and CDC and other public health agencies is a part of the credibility of the office. And I hope that office will never lose that credibility. We will have to fight with the politics of Washington and elsewhere, but the credibility which the American people have attributed to that office is what's really critical. Now, there's a story which I like to tell about Luther Terry. And of course, when he was on his way to release the first ever Surgeon General's report, he was in the back seat of his car with his assistant. He was being briefed for his release. And he was smoking more than usual. So his assistant said, well, Dr. Terry, do you know the first question they're going to ask you when you release this report? He said, no, what's that? They're going to ask you if you smoke. And Dr. Terry said, oh, no, why would they ask me that? I mean, that's a personal. So he went on to the press conference, did just a great job of releasing the report. First question, Dr. Terry, do you smoke? He said, no, I don't. And so the reporter had done his homework. So he said, well, Dr. Terry, when did you quit? And he said, I quit 15 minutes ago. And he never smoked again. In fact, Captain Farrell and I were at the Arlington Cemetery and laid a wreath at Dr. Terry's grave, and a lot of the family members were there, and Michael, who's the best known, and others, but they often talk about the fact that their dad walked around the rest of his life with the lapel pin saying, thank you for not smoking. The credibility of being able to quit, which is tough in and of itself, but to really go from being a victim, of this powerful addiction to a leader in helping people to quit is really something to be said for the Office of the Surgeon General. We know that smoking is a serious addiction, but we also know that the credibility of the office. So one lesson for the last 50 years, and I want to say that we estimate that 8 million lives have been saved since 1964 because of that report. Now, we've lost 20 million lives in the United States from smoking. But because of the fact that people quit and the fact that we've gone from almost 50% of the American people being smokers to now 18%, it's another way, Dean, of looking at the 18%. And the United States sort of leads the world in the extent to which we have been able to get people to quit smoking. And that's important because the World Health Organization just met a few years ago, I guess it was 2003, and the goal now is to really get people all over the world to quit smoking or for children not to begin smoking, because we know that 90% of people who are addicted to smoking begin smoking before they're 18 years of age. So David Kessler was right. Smoking is a pediatric disease. But what I said on that occasion was that what Dr. Terry did was to begin a relay race, right? it was not just Dr. Terry's report, but every Surgeon General since Dr. Terry has released at least one report on smoking and health. And why? How can we keep releasing reports on the same topic? Because the research continues. Powerful, in-depth research, learning new things. Dr. Terry did not know the dangers of secondhand smoke, but Surgeons General coming after him, including starting with Steinbach and then Coop and Richard Carmona, made it very clear the dangers of secondhand smoke for everybody. He didn't know that. The science was not there. Dr. Terry did not know that smoking was a pediatric disease, that 90% of people who were addicted to smoking became addicted while they were children. So we keep learning new things and we keep issuing new reports. It's like a relay race. This responsibility for the health of the American people, to protect the American people from smoking, is like a relay race. Leadership is like a relay race. I mean, whatever you do as a leader, somehow you got to figure out a way, number one, not to drop the baton, right? It's a real challenge. And secondly, to make sure that you pass the baton smoothly to other people. Well, so when we talk about developing leaders at Satcher Leadership Institute, we try to select people who have a commitment to leadership, and especially a commitment to the reduction and ultimately elimination of disparities in health. We look for those kinds of people, and then we try to enrich their talents and their commitments so that they will not only not make the same mistakes we may have made, but in fact take the baton and go faster and further than we could have ever gone. We have 5 divisions at Satcher Leadership Institute. The Health Policy Institute sponsors the fellowship program. And I'm tempted to just talk about that because I know that there are students in the audience who one day might well end up at our Health Policy Institute as a fellow. But it's a program, a 10-month program where people come on board and through a year of interactions and community engagement, develop leadership skills. We have a Center of Excellence for Sexual Health. In fact, we have the only endowed chair in sexuality and religion in the country. I know you think those two things don't always go together, but we do. And we especially believe that the church has a tremendous role to play in sexuality, and especially helping young people to deal with their sexuality. Community Voices is a Kellogg Foundation funded program where we actually work with communities all over the country to engage them in efforts to improve, especially access to quality health care. Health Promotion and Disease Prevention is the program that sponsors the community health leadership component. We invite churches and other community organizations to refer people to us who spend 12 weeks, 1 day a week, studying health promotion and disease prevention. And I remember writing to pastors of churches and inviting them to select somebody from their church to come and go through this program. And to date, 12 pastors have referred themselves. And but the good thing is they've gone back to their churches and started some very interesting programs. HIV/AIDS prevention, physical activity, good nutrition. So some very strong things have come out of that. And so we're very pleased about that. But my favorite program is actually in the Behavioral Health Center. 3 years ago, 4 years I guess now, we started the Quality Parenting Program. It's called Smart and Secure Children Parenting. And it focuses on the period from 0 to 5. And the idea there, as Gail Walensky and I wrote in the Journal of Health Affairs after the Social Determinants Report, the idea is that if in fact we can make sure that children have a healthy pregnancy, and there are a lot of things that we can do, right? And some of these parents, maybe single parents, 80% of them are single parents, a lot of them know that there's some things that they can do differently. So they work together to make sure nobody's smoking during pregnancy, that they engage in good nutrition, and that the baby has the best chance of a healthy pregnancy, in which, by the way, the major development of the brain takes place between 10 and 18 weeks. A lot of delicate things happen in those early periods that we can really help parents to make sure that babies have the best chance of survival. Now, Dean Reese has just walked in, and I have so much respect for him, I'm tempted to stop and let him. How long do you have here, Al? Are you okay? All right. Welcome. So we've graduated 3 classes of parents in this program. They graduate in June just like everybody else, and then some of them become part of the leadership development part of our strategy. But we made a decision early in this program, and this is important, I think, for community engagement. We made a decision that it was not enough for us just to feel good about what was happening in this program, and it felt very good. I mean, when you feel good about working with 100 parents a year, helping them to be better parents, helping them to communicate better as a child developed, helping the child to read as early as possible. All these things were happening in the program. And yet we decided that it was not enough just to feel good. So we introduced some measures. We were going to measure breastfeeding. We were going to measure child obesity and, in the early years. And we're going to measure development in terms of behavior and learning. So we initiated those measurements. And then I told you that our philosophy is that everybody teaches and everybody learns. Well, the parents came to us and said, well, aren't you concerned about what's happening to us as we do these things for the baby? And it took me a little while. We're slow, even though we're supposed to be leaders. So they said, aren't you concerned about what's happening to us? And we decided to measure depression, because depression has been increasing, especially in black women in urban communities. And sure enough, what we found was that in the women who participated in this program, depression was going down. The risk of depression, the experience of depression, which is really important, by the way, for the health of the child. Depression in mothers, serious problem for child development. But I want to make it very clear. I want to confess that with all my degrees, I didn't think of that. The parents thought of it. And NIH has now funded us to replicate that program in 12 states in the country. But I think the message is that parents are leaders. In some ways, they may be the most important leaders, but we wanted them to see themselves as leaders. We wanted them to see themselves as the most important people in this process, working for the health of the child. So we have these 3 leadership development programs, and the CDC has funded us to expand the community health leadership program to 6 states, and NIH through the transdisciplinary collaborating centers has now funded us to go into 12 states with the parenting program. Well, public health is something that's dear to me. Obviously, I've worked in public health for a long time in the community. We were talking last night about the Sickle Cell Research Center. I started the center out in Los Angeles in 1973. And the community part of that was really a critical part. And it taught us a lot. And people like Lou Sullivan, Marilyn Gaston, Clarice Reed, I can name a lot of people who developed their leadership, not necessarily skills, but certainly they became prominent in leadership roles as directors of sickle cell centers. But so how do we define public health? And there is certainly more than one definition of public health. But I like the Association of Schools of Public Health's definition, and I believe this came out in the late 80s, I believe. And I know it's the one that we focus on at the CDC in the early 90s. So what is public health? It's what we do collectively, right, as a society to create the conditions in which people can be healthy. That definition stands the test of time. Think about it, social determinants of health. You hadn't even heard the term in 1988. And yet public health was defined as what we do collectively as a society to create the conditions, right, in which people can be healthy. So I'm comfortable with that definition, and I know it's not the only one, but I think it's important for us to realize how important that challenge is for us. That condition may well be the condition of the womb, right? when the baby is developing there. It may be making sure that people are not exposed to secondhand smoke, and California was the first state to pass legislation in 1987. When I released a report on women and smoking in 2000, by the way, we pointed out that in the year 2000, 27,000 more women died from lung cancer than breast cancer. However, the only state in the union at the time where lung cancer death among women were not increasing was California. And California had passed legislation restricting smoking in public places. There are now 26 states in this country that have such legislation. And that's another thing that came from the Surgeon General's reports on smoking and health. It is that as you learn these new things, they've got to be translated into policy. And of course, if you remember, social determinants of health can generally only be influenced by policy. And certainly, we had done a lot of great things for smoking and health, but when we started to introduce policies restricting the sale of cigarettes to children, policy restricting exposure of children to smoke, that's when we started to make a difference. And then when states boldly said, you cannot smoke in public places, the benefits were not just from not being exposed to the smoking, it was that it changed the social milieu, right? Isn't that what we say in public health? Is that if you can change the social milieu, you can make progress. So this legislation made it such that it was irresponsible to smoke in public. It was no longer cool. You remember when it was cool to smoke in public? It was no longer cool. And for teenagers, it was very important to send that message. It was no longer cool. Well, what is the public health approach, and has that stood the test of time? Can we stand here today and say that the public health approach still works? It certainly worked for infectious diseases, right? We have an Ebola outbreak now in Guinea. In 1995, when I was director of the CDC, we had an Ebola outbreak in Zaire. 240 people died. 30% of them were physicians and nurses. And we sent a CDC team over there, well-trained. In fact, I thought I would have difficulty getting people to go since so many people, including physicians, were dying. I had so many people volunteering to go to Zaire until we had trouble selecting the 5 members who went, but they were able to control the outbreak within 10 days. But it's the public health approach that was applied. We ask ourselves, what is the problem? And you can describe all the things that happen to people with Ebola, you know, the vomiting, the bleeding, and all of those things. But when you describe what's happening and how many people are affected, it's the first step in the public health approach. It's like surveillance begins there, right? And then the second question is, what is the cause of this? What is the risk? And it's not always easy to answer that question. Throughout our history, of course, scientists working in the laboratory have answered that question, right? You mentioned HIV/AIDS. And there were 2 scientists at the CDC who had to approve the release of certain drugs. And this was this one drug that they had approved for older people who were debilitated. And all of a sudden, they were young people having symptoms that you would only see in older people who were debilitated. And so CDC sent a team out to Los Angeles and New York, and sure enough, these were young men, primarily at that first time, gay men, but it was clear later that it was not limited to gay men. So what is the problem? But then what is the cause? And it's when we're able to detect the organism in the laboratory and say that's the cause. So what works to prevent it? Well, we don't have a good answer for that question for Ebola, except Ebola tends to burn itself out, right? It kills its victims so fast until they don't have a lot of time to spread it to other people. So it's a blessing in disguise in a sense that Ebola kills rapidly, or else when an Ebola outbreak took place in Guinea, it would spread all over the world rapidly. So far that has not happened. But what I want to say today is that the same approach works for social determinants of health, and it works for obesity. We released the report on obesity in December of 2001, And in that report, we called childhood obesity an epidemic. Now, that was strange. Nobody had ever called a chronic condition an epidemic before. We'd reserved that for infectious diseases. But what we found through surveillance was that childhood obesity had tripled between 1980 and 2000. So we felt comfortable calling it an epidemic. Well, we were wrong in the sense that it was really a pandemic, but we didn't know that. We didn't know that all over the world, people were eating the same way we eat in the United States, increasingly. That you had McDonald's and Church's Chicken and all those businesses springing up all over the world, so people were getting fat all over the world. And so it was, in fact, a pandemic, and we know that now, and we're taking a pandemic approach. But the real difficult thing sometimes, of course, is how do you take what you've done, and this can be an immunization program, how do you replicate that? When I became director of the CDC, only 55% of the children in this country were being immunized by the age of 2. Only 55%. And a country that has more money than any country in the world. In order to get those numbers up to 80% and to eliminate disparities, and that's one of the areas where we've done a great job of eliminating disparities, we had to come up with some strategies. We had to engage the WIC program, the Council of La Raza, the National Conference of Black Churches, all had to become involved in immunization programs in order for us to get the immunization levels up in this country. Congress became involved and eliminated the financial barriers so that children who didn't have money still had access to immunizations. Now, I don't have to tell you that social determinants of health are complicated, so right now we're worrying about the fact that many children are not being immunized. I think it's up to about 5% because of religious belief or other things. And so now we're seeing the reemergence of measles. We're seeing a lot of diseases that we thought we had under control beginning to reemerge. But those are social issues, right? And we have to deal with them. It's the new public health in a sense, but it's the social determinants of health. So what impact has the social determinants of health had on how we do public health? Well, look at our language. I wanted one or two objectives, one or two goals for Healthy People 2010, which we released in January of 2000, of course. But we didn't want to have 5 goals. We wanted the American people to wake up in the morning and say, I know what the goals are. We want people to live healthy, quality lives and not just get old and be sick and incapacitated. And we wanted to eliminate racial and ethnic disparities in health, and we added to that later on. Well, also, what happened between there and 10 years later? Why is it that 10 years later we talk about attaining high quality, longer lives, free of preventable diseases, et cetera, but we also talk about health equity that we had not talked about before, with different implications in terms of looking generally at the population. We continue to talk about eliminating disparities, and I'm using we loosely. I had nothing to do with 2020. I was out of government. But it was great to see, I hope you see it, that the Commission's report on social determinants of health is reflected in Healthy People 2020 goals. That's the difference. It is seeing it from the perspective of social determinants of health. Create social and physical environments that promote good health for all, social determinants of health as well as other determinants, and promote quality of life, healthy development. So between Healthy People 2010, which started in 2000, and Healthy People 2020, which started in 2010, you have the impact of the social determinants of health, the impact of new science, right? Just like Surgeon General's reports, the impact of new developments. Well, this is, we went too far behind, however, because in Healthy People 2010, some of you remember, we had this, for the first time, this chart on determinants of health. We had never used the word social determinants of health, but we were basing this on a New England Journal of Medicine article, which Bill Fagan and Mike McGinnis published in 1993. And they listed 4 major determinants of health. They were access to quality health care, the environment, genetics or biology, if you will, and then behavior. And they asked the question, what's the relative impact of these various determinants? And based on the data available to them, They said that access to quality health care accounted for 10 to 15% of the variation in outcome. That was very upsetting to some people, but they were able to back that up. They said that genetics or biology accounted for 20 to 25% of the variation, environment 20 to 25%. However, behavior, they said, accounted for 40% of the variation in outcome. Whether or not you smoked, whether you were physically active on a regular basis, whether you consume adequate amounts of fruits and vegetables, those were the behaviors. However, something we didn't even mention, but it was there, right? Overriding all of this, policies and intervention. In other words, you can talk to people about needing to be physically active 5 days a week, 30 minutes a day at least. You can talk to them about fresh fruits and vegetables, but if there are not policies in place which allow them to do those things, it's unlikely that they will do them. And what do we say about the social determinants of health? They depend upon policies. This is what we said. The report of the Commission on Social Determinants of Health can be summarized in these 3 statements. And we started with these last week in Italy when we had our sort of reunion. What are the social determinants of health? They are the conditions in which people are born, grow, live, work, and age. They're shaped by the distribution of money, power, and resources at a global, national, and local level. These social conditions that have so much to do with health outcomes are shaped by how we distribute money, power, and resources all over the world. I mean, I can show you the risk of under 5 child mortality all over the world, and you will see that in those countries that are poorest, you have the highest risk of a child dying before the age of 5. We know that. In the last 5 years, we have reduced under 5 childhood mortality from about 12 million children a year now to about 6 million. But we've had to broaden our perspective about why are these children dying, and some of those are not medical issues. Kids can't get safe water, so to drink water is a risk. So we've started to target that. And then finally, social determinants of health often require policy change. Isn't that interesting? Policies and intervention right up there, but we didn't hardly mention it. And yet the social determinants of health require policy change. Policies like restricting smoking in public places. Policies like making sure that every person has access to the opportunity to be physically active or to engage in good nutrition. And what we know in this country is that there are people who live in communities where it's not safe to walk out on the porch, let alone to be physically active in terms of jogging or going to the park. We can change that, and I think we will change it. But we've got to be aware of it to begin with. One of my favorite stories is about the man who was traveling across the country in a hot air balloon, and at a certain point, he realized that he was lost. He had no idea where he was. So he decided, I'll lower the balloon and see if there are any recognizable landmarks. So he lowered the balloon. He didn't see anything he recognized, so he just kept lowering it. And it was only after he got to about 30 feet above ground that he spotted a man working in the field below. So he yelled out, "Where am I?" And the man stopped digging and he looked up and said, "Well, you're in a hot air balloon about 30 feet above ground." The man in the balloon said, "My goodness, you sound like a scientist. Are you a scientist?" And the man on the ground said, "I am a scientist, but how in the world did you know that?" He said, "I knew that because what you've told me is technically correct, but it have absolutely no use to me right now. None." Well, not to be outdone, the man on the ground said, "Well, you sound like one of those policymakers from Washington or somewhere." And the man in the balloon said, I'm a leading policymaker, but how in the world did you know that?" And the man on the ground said, "I knew that because you're in the same position you were when we met. You don't know where you are, you don't know where you're going, and now you're blaming me." Well, there is a moral to that story. There's a moral to that story. And I hope it's clear, and that is that we've got to continue to do the science. we've got to continue to adequately fund research. We cannot make that mistake. And there's nothing about the social determinants of health says that we should reduce our funding of research. It says that we should broaden it, right? So NIH is now funding R01s in social determinants of health. They're funding centers like ours, Health Equity Policy Center, transdisciplinary collaborating centers. We've got to continue to do the science, and as you're doing here, we have to continue to broaden that science. We need experts in social determinants of health. And finally, you're probably familiar with the McKinley model, and ignore the fine print there. But I do want you to reflect on the fact that we intervene in at least 3 different ways. And I didn't say 3 different places, but I did say 3 different ways. Downstream, we deal with individuals. In medicine, we deal with individual patients. We educate individuals. We deal with individuals downstream. Midstream, we deal with the community. And I can tell you, since we released a report on overweight and obesity, it's been one of the best examples of community intervention. It's been working with the schools. It's been a tremendous First Lady and the Let's Move project, really targeting the community. We've got to engage communities. We've got to energize communities. And that's been critical. And so we're now able to say that we've seen a reduction in childhood obesity between ages of 2 and 5. Maybe as high as 42% reduction, maybe. But we're making progress. Well then, so what do we need upstream for? We need upstream because we need policies that support these things. We need the Child Health and Nutrition Act of 2010. And how was it different? It said the U.S. Department of Agriculture must send healthy foods to schools for free meals. Not just any foods, healthy foods. That's what it said. The Child Health and Nutrition Act of 2010, unlike 2004, said that 20% of the children in this country are hungry. And we've got to find a way to make sure that we get food to hungry children, or else they're not going to learn. Because what the science had told us something, by the way, and I was pleased to be a part of that first report in 2005, showing that children who were physically active and engaged in good nutrition, especially healthy breakfast, learn better than other children, right? They perform better on standardized exams in reading and math. They were better disciplined in the schools. And then later, scientists at the University of Illinois showed that if you do imaging of the brain, what you see is that in the hippocampal area that's responsible for memory and storage, in that area, when children are physically active, you see it, the hippocampus lights up. Better circulation in that part of the brain that's so important for learning. So what we observed in the classroom, scientists now observe in the brain in terms of how the brain responds to physical activity and good nutrition. So upstream, we deal with policies. We want to make sure that people have equal opportunity, if you will, to be healthy, right? Equal opportunity. In other words, we don't have an equal opportunity to be physically active if there's no park in your community. You don't have an equal opportunity to engage in good nutrition if there's no grocery store. So how do we as a nation make a commitment, especially as it relates to children and child development, to make sure that the policies are such, and upstream is where the policies take place. It's not a place, it's a function. Because school districts have policies, right? Some school districts cut out physical education and say, we don't have the money. Other school districts says, this isn't too important. So policies, certain teachers make policies in their classroom. We had some policies in my house at home, but I won't tell you about those. I have the scars to prove it. So policies occur, in a lot of different places, but it's an upstream function when you change policies. Now, this is the Surgeon General's prescription, which I released in 1999. President Clinton asked me to represent the United States at an international conference on health. And we only had 5 minutes to speak. There were 189 ministers there, and I was representing the United States. And so we completed this prescription. Now, it talked about the things you know so much about is that how important physical activity is, good nutrition, and we had to limit it so people could know, because nutrition is still very complicated. There are not a lot of physicians who know a lot about nutrition. I hate to admit that, but it's not one of the areas where we've done the best job. But we do know that we need to eat more fruits and vegetables. And I could add to that low-fat milk and grain and lean protein. We need to avoid toxins, a no-brainer. That's what the Surgeon General said 50 years ago for tobacco. We need to be responsible in our sexual behavior. Even if there were no HIV/AIDS epidemic or all of the other epidemics, we need to be responsible because it's our responsibility to be healthy and to protect the health of other people. And we need to participate in daily activities to reduce stress. I can tell you, you wonder what keep surgeons general going? Physical, we all, Rich Carmona and I are very active physically. Everywhere where we go, we keep that up because it helps to reduce stress, in addition to all of the other benefits. So I'll close with this quote from the Satcher Leadership Institute. It says that in order to eliminate disparities in health, we need leaders who first care enough, but we also need leaders who know enough. We need leaders who have the courage to do enough and who will persist until the job is done. That's what we need, and I hope that you will be a part of that leadership. Thank you.
Thank you, Dr. Satcher. So we will take a few questions now. I ask you to stand up and project your voice.
Dr. Satcher, thank you. That was an inspirational presentation. I was particularly interested in your comments about the rising number of people who are avoiding vaccines for their children. And it is my perception, and I'm ready for you to tell me that I'm wrong on this, that these are not the poor and undereducated who are doing this. These are people with a certain amount of education who are simply reading the wrong things and believing the wrong things, mostly on the internet. So I'm wondering what you might prescribe to those of us in the broader public health community to do to refute the misinformation that is out there regarding vaccines.
Very, very important question. And let me say that we have had several studies of this issue, in terms of whether, in fact, there's a relationship between measles, mumps, rubella vaccine and autism and other things. We brought together the best scientists that we could find all over the world to look at that question. And in every case, there's been no evidence that these vaccines increase the risk of autism. And yet there are some people who still believe it. And then one of the things we teach our fellows is that sometimes deeply held beliefs can be as important as science. So people make decisions on the basis of deeply held beliefs. So what do you do? Well, you just keep at it. You keep at it, you keep producing the science, you keep aggressively educating, because we're putting a lot of people at risk. Not just those who don't get immunized, by the way, and we now estimate, about 4.5% of children who are not getting immunized because of that belief. When I was director of CDC, it was 1%, and we thought that was a big problem. It was in the fact that it was increasing. Now it's about 4.5 to 5%. So what does it mean? It means that, and there are some children in the country who can't be immunized because of their immune status or something like that. And we have what we call herd immunity, right? When you can immunize most of the population, it protects everybody. But when you don't immunize part of the population, it puts those people at risk. When somebody comes to this country traveling who've not been immunized, and then there are people here who've not been immunized, and those people are carrying measles or mumps or whatever. So it is putting a lot of people at risk. We've got to be more aggressive with that message and hope that it will get through. And that happens. Sometimes it takes a long time for a message to get through, and you have to be really aggressive about making sure that people understand all over again the importance of child immunizations, of protecting our children, and also, however, protecting that midstream, the rest of the population. We got a lot of work to do.
I'm going to encourage young students and young public health service officers. You've got one of your heroes. Yes, ma'am.
My name is Victoria. I spoke to you earlier on this morning. Based on what you just asked, so how do we get people who are getting off from different countries like me get immunized before we enter in the United States?
Are you from Sierra Leone?
Yes, I spoke to you.
Okay. Good. Well, that's a very good question, and I thought that was pretty well taken care of. Now, when you're actually moving to the United States,
Well, like for visitor, he mentioned about how do we get people get immunized. You mentioned about it. So for us that coming in the United States, there's a large area that we're dealing with public health.
yeah.
Do we reach to other countries to get
Oh, other countries, sure. Oh, I have to, that's a very important question. It's one of the areas where we've done better globally than probably any other area. The global vaccine program, which started, in 1980, 81, has been one of the most successful global programs that we have. Now, that doesn't mean we can't do better. I remember when we were, we developed these computer programs so that if a child was seen in a doctor's office and the mother didn't know whether the child had been immunized, we had a computer program where you could get information from all over the country. You remember that? So, but you know what? I went to Zimbabwe, and I visited this, and immunization levels were 80% there, and they were less than 80% in this country. Do you know what they used? They had a card that you had to use to get into the clinic. And on that card, you had to have the immunization status. If it wasn't on there, you couldn't get on the bus to go to the clinic. They had an 80% child immunization rate, and this was in 1995. So, there are a lot of ways, if we get serious about making sure that our children get immunized, there are a lot of ways we can make sure that happens. But it's a good question. I think we have to keep working on it. The CDC and the World Health Organization have made childhood immunization a priority. And I mentioned the problem we're having in this country, and I'm sure that it's going to be a problem in other countries too. But we did for a while get immunization levels up throughout the world pretty good. I remember spending a week in India, and I was with Mariah Chatterjee last week. She's head of the Self-Employed Women Association. But I remember when I was director of CDC, we had this big polio immunization effort in '96, I believe. Spent a whole week there. 100 million children were immunized. And in 1996, there was polio in India. I went back to India in 2009. I didn't see a single child with polio. The only people I saw with polio were adults who didn't get the immunization when they were children. I'm not saying that to say we've solved all the problems. I'm saying that it is one area where we've made dramatic progress. Now we're trying to make that kind of progress with smoking. Developing countries represent the areas where smoking is increasing most rapidly. And of course, the World Health Organization is now targeting that and trying to make sure. And we ought to be proud of what this country has contributed to that message. We've had the greatest decline in smoking from almost 50% to 18% of any country in the world. That's one area. So the Surgeon General's reports have made a difference. We're not happy. We're not satisfied. But the fact of the matter is, it's one area. So you go from childhood immunization to smoking and health. It's just dangerous for children to be addicted to cigarettes. So we've got to keep working to make progress. It's a very important question, and you might want to look into it further with the CDC and WHO. But it is an area where we've managed to work together to make some progress. But it's at risk. It's at risk when we stop immunizing.
Dr. Satcher says one more, so I go with him. Sorry, Jane. Woody?
Well, that's Woody Kessel.
I know. I had to go for Woody.
So if you don't let him speak, we might have some problems.
Their relationship hasn't changed in 30 years, David. Again, thank you so much for your inspirational comments for all of us. My question relates to, you mentioned the importance of recognizing overweight and obesity as an epidemic and how it contributed. You also mentioned the import of mental health. I'm hoping you would comment about another literally killer in the United States, violence. And violence something that, frankly, we've become desensitized to, except when there's an article
Yeah.
in the newspaper, and how you would see us taking that on to try to reconcile, as you did with your leadership in so many other areas.
Yeah, I became Surgeon General shortly after Columbine and got quite involved with the students at Columbine. And the only report I released that was requested by both the White House and the Congress was the Youth Violence Prevention Report, and I recommend it to you. It's very interesting. Even though both the President and the Congress asked for that report from the Surgeon General, and it was well funded, by the time the report was released, you know what usually happens in this country? We forget. As long as the news die down, it's no longer in the headlines. So we still haven't dealt with the issue of youth violence. And too many of our young people, especially young people of color, are dying. You don't read about that as you do when there's a major shooting somewhere. But every week in this country, every weekend, really every night, there are young people killing each other, young people who believe that the only way they can be secure is to have a weapon and to be a member of a gang. That's what it's sort of come to. And so it is still a major problem. Marion Wright Elliman and I did a program, I guess at the National Cathedral, and Mark Rosenberg on this issue, and just really trying to gain. It's very unfortunate that it's become so politicized around gun control. People are dying unnecessarily while we play games, you know, with politics. So it's a very serious problem, and I appreciate your bringing it up. I remember working on that report. I remember the interaction. In fact, I saw one of the students from Columbine. He introduced me. I went to speak somewhere in Florida last year, and he was in a wheelchair because he'd been shot. But he was doing well, had a great job in California. But I mean, the suffering that people go through in incidents like that, but more important, every night, every week in this country, young people being mutilated by violence. Okay, thank you.
Thank you, Dr. Satcher.